All right, so hi everyone. Thank you so much for coming to the Feminist Health Research Conference hosted by Medical Herstory. So my name is Tori. I'm the founder of Medical Herstory, and I'll be your co-host for today along with Rachel. So I'm going to quickly introduce you to gender health inequity. What is it? A little bit about Medical Herstory, and then I'm going to pass it over to Rachel to introduce our amazing panelists. So what exactly is the problem that we're all here today trying to address? That's gender health inequity. So social structures like sexism, racism, and ableism infiltrate medical care and they cause harm. These inequities become both institutionalized and embodied by individuals, and bias and stereotypes cause women's pain to be ignored and naturalized, and their concerns to be dismissed. As a result, many women struggle in silence with medical conditions due to fear, embarrassment, or stigma surrounding their bodies. These inequities are further exacerbated for low-income, disabled, trans, and racialized women and non-binary people. So this is where Medical Herstory comes in. We're an award-winning not-for-profit dedicated to helping people better understand gender health inequities and advocate for gender health equity through storytelling and undoing stigma. So we do this through a few ways. Through storytelling, we run an online publication where women and femmes can submit their stories about navigating health and illness. We hold educational events like this one, where we raise awareness and promote research that promotes women's voices. And we also conduct advocacy through our outreach team, volunteers, and workshops in order to destigmatize discussions around our bodies. So Medical Herstory takes a feminist approach to all of our work, and today we'll be talking about how the same feminist lens can be applied to health research. What makes research feminist? Feminist research acknowledges that all research and researchers are embedded in a specific time, place, and social location. It recognizes that individuals are the experts of their own lived experience, and it listens to both the words that are being said and the larger social and gender discourses at play. Furthermore, it includes groups whose voices have previously been excluded in research. So today we're going to be talking about feminist health research and looking at what this opens up. So we're going to get to look at experiences of health and illness, healthcare provisions and treatments. Feminism helps us ask questions about who is included and who is invisibilized, as well as subverting traditional narratives by looking at who becomes marginalized and who becomes medicalized and whose voices are really being heard. We'll be delving into all of this today. Please stay tuned until the end. And now I'm going to hand you over to my co-host, Rachel, who's just going to quickly explain how today's going to proceed and also introduce our amazing panelists.
Thank you to Medical Herstory for that introduction. And thank you to Alana Cutland, Feminist Society, for sponsoring this event. So the schedule of our panel today is panel 1 will be called Disruptive Voices, and we'll have 3 panelists, Tori, who we just heard from, Oyinkan, and Ella. And then we'll have around 15 minutes of question and answer. And then for our second panel, we'll be talking about creating community. And I will be presenting Lotte and Scott with another 15-minute question and answer at the end. We're all part of the MPhil program in health medicine and society at the University of Cambridge, which is an interdisciplinary program from the history and philosophy of science, the medical anthropology, and the sociology of medicine departments. Some quick Zoom rules: please keep yourself muted throughout the conference. As I said, there will be a Q&A following each panel. And if you have a question, you can either write it in the chat and we can ask it out loud, or if you want to be able to, ask it in your camera, you can write your name and then we'll call on you and you can ask your question. As Tori said, this event will be recorded, but if you want your question removed from the recording, you can just let us know. And finally, we hope you just sit back, relax. We hope you learn a lot. And you can follow us on Facebook or Instagram at Medical Herstory to give us feedback or let us know your thoughts. So I'm going to kick it off by introducing Tori with the first session. Thank you.
Today, I'm going to be doing a talk called My Medical Herstory. This presentation is going to offer some insight into how I link my activism and academics through feminist health research. So can anyone guess the common thread that lays at the heart of both my activism and academics? If you guessed a chronic yeast infection, you'd be right, and you're probably familiar with my work. So today I'm going to be giving you an introduction to feminist health research, where I'm going to use my lived experience of living with, speaking on and educating others about chronic yeast infections as a case study of how you could do feminist research. So I'm going to be walking you through a brief outline of my methods and sort of some of the decisions I made and what the outcomes of these were. So I'm going to be going over feminist phenomenology and what this complicated word means. I'm going to delve into embodiment, my own lived experience, and how these impacted the interview process. And then I'm going to briefly outline my results as well as their implications. Today, you're all going to be hearing presentations that seem like we all entered Cambridge with a wealth of knowledge and months of preparation. Let me tell you, this surely isn't the case. So for me, why did I choose chronic yeast infections? Honestly, I didn't. I applied to the program hoping to study history and to do a dissertation on nymphomania. That quickly fell through and I found myself a bit lost and scrambling. So I chose to write about something I know. Not from any years of academic research, but instead from lived experience. I have lived with chronic yeast infections for 4 years, and I've spent hours searching for cures. In this searching, I realized that there's really not a lot of academic research on this topic, and I chose it because I knew that studying something for 9 months that I lived with for 4 years would not be a topic that I would soon become bored of. So to recruit participants, I posted an online flyer recruiting young women who had experienced a yeast infection that kept coming back or that would not go away. I recruited young women due to the average age of onset of chronic yeast infections, as well as my interest in how that crucial time in your life would be impacted by these infections. Feminism was central to my project from the start, and I adopted a feminist phenomenological approach to illness. Phenomenology basically is a term that explains how experiences are embodied, meaning that they are fleshy, physical, and bodily, and that these experiences are tied to culture, meaning that the ways that we experience our culture are tied to a specific time and place, and that they're by no means universal. It means that when we speak about our bodies and listen to others, these conversations are never purely biological, but are linked to larger social and gender discourses. And since illness can disrupt our bodies, our identities, and our understandings, phenomenology is especially useful for understanding illness experiences. So in my research, I focus on this embodied aspect of illness, specifically infection, to understand how gender norms and social discourses can both shape and be shaped by how biological processes and illnesses are understood and experienced. So feminist scholars reject the possibility or even desirability of a detached, value-free researcher who's disembodied and has a neutral gaze from nowhere. Instead, they advocate for a view that comes from the body, and they advocate that the researcher's own social location and lived experience are epistemically significant. So as a feminist phenomenological project, this study begins with women's lived experiences, including my own. As mentioned before, I'm all too familiar with chronic yeast infections, but research was not the first avenue by which I chose to speak publicly on the topic. 2 years ago, I was completing my undergraduate degree at McGill University. I know a lot of people in this call today are from there, so shout out to all of you. I was studying gender, sexuality, feminist, and social justice studies, but I was also dealing with an unrelenting chronic yeast infection and immense discomfort, dealing with a lot of shame and embarrassment, all in silence. I'd been visiting multiple physicians and specialists only to be dismissed with advice such as wear white underwear or stop having sex. Or my GP's favorite signature slogan, some people get colds, some people get chronic yeast infections. I had tried everything, I Googled everything, I was frustrated with lost test kits, invasive exams, and ineffective treatments. But I did decide to speak out. How, you may ask? I published an article in our school newspaper. It went on to make the front page, and I started hearing from other women who had experienced similar situations of medical mistreatment. Inspired by all of these raw and honest stories, I figured we needed a platform to share these women's voices. And so I created Medical Herstory. Since then, I've done countless print, radio, and television interviews on my experience, and it is my lived experience that gave me an insider perspective into this illness, but it is my activism that meant that other people knew about my experience and was vital to why this project was a success. As the women I spoke to were both aware of my activism, And for most of them, reading the article I'd published in the school newspaper was the first time that they had heard of chronic yeast infections before having them, or that they were able to recognize what they'd been going through. So for all this talk about chronic yeast infections, what are they? We know that 75% of people with vaginas will have at least one yeast infection in their lifetime. These are usually easily treated with an antifungal and go away in a few days. But for 5 to 10% of women, they experience recurrent symptoms on a weekly, monthly, or constant basis. We know that chronic yeast infections are the result of a fungal overgrowth, but many have no identifiable cause. And as a result, many people feel blamed for their own symptoms because they can't find a cure and just feel that they're doing something wrong. And as some participants described them, they are debilitating, embarrassing, and draining. So the interview process. Because of the stigma and shame surrounding infected genitals, many of the women had not spoken about this topic with other people, even their close female friends, and therefore the interview process was often the first time that they were speaking out. So I spoke with 6 women between 20 and 23. They were located in the US, UK, and Canada. And on average, they'd been living with chronic yeast infections for 2 years. At the time that we'd spoken, 4 had not recovered, but 2 of them had. The majority were white women and all had a university education. And I'd like to acknowledge that our similarities in age, race, and education levels likely facilitated such an open conversation. And this brings me to the common illness experience. So I'm not going to present all my findings today. If you're interested, you can reach out or you can check out Medical Herstory's YouTube channel where I go into them on depth. But today I'm just going to tell you about what emerged across these interviews of diverse women from different backgrounds, but that remain the same. So the women explained that Western society has this ideal vagina that is seen as fresh, clean, and smelling like flowers. The women I spoke with therefore said that they came to embody the opposite of ideal genitals and instead embodied the cultural fears around infected, leaky, and gross bodies. The women I spoke to most had sought medical care across the US, UK, and Canada, and they all surprisingly reported very similar results. They said that yeast infections failed to fit within a neat category, and that as a result, they bounced between multiple physicians who really didn't seem to care. They said they were constantly asked patronizing questions such as, "Are you changing your underwear?" And the women had tried everything from antifungal treatments to behavioral modifications without relief. One of the participants even avoided medical care and questioned why other women would seek it out, believing that physicians had nothing to offer in this case. The interviewees explained that physicians normalized chronic yeast infections as simply a woman's problem that was mundane and that simply did not have urgency or concern. Social discourses normalize chronic yeast infections by insisting that vaginas are simply the ideal breeding ground for yeast, and therefore chronic yeast infections are just one diagnosis that's part of a larger picture of how women's pain is dismissed and overlooked. Interestingly, though, while women did resist this normalization from physicians and tried to find a cure, they also internalized these discourses as they moved from seeing chronic yeast infections as something which was happening to them to a part of them. They described this relationship vividly as either being like a symbiosis between themselves and their infection, or like a catchy song that gets stuck in your head, or a personality trait. But I argue that this process was not inevitable, but it was the result of women lacking a cure and feeling that they must address these issues alone. This brings us to the paradox of a normal problem. So the normal problem is that if societal discourses stigmatize women's normal genitals as pathological, then women's genital pathologies become normalized. So what I'm saying here is that without denying the fact that yeast infections are normal, as in biologically common, I want to argue that physicians, intimate partners, and women themselves normalize their experiences due to a lack of effective medical treatment and these social discourses tethering women's gender and genitals to infection. And as a result, the onus of care and cure become placed onto the individual to address alone while obscuring these larger gender dynamics. So implications. There's a lot that could be said with the results that I've presented here today, but I'll just go through a few. So normalization of chronic yeast infections can lead to a lack of clinical research, because if yeast infections are normal or inevitable, then what's the point of looking into them more? it can result in women avoiding medical care because they can either have a negative experience when seeking out care and therefore choose to avoid it, or they can believe that yeast infections are simply not something worthy of healthcare. This can then lead to self-treating or engaging in dangerous bodywork practices as women attempt to rid themselves of this stigma around infected genitals, but then actually can exacerbate the infection. And finally, it results in feeling that they must cope alone and in silence. So what do I think we should do about this? I think we should normalize discussions of our bodies and not women's pain. I think we need to address the structural inequalities within healthcare, and that we need to create communities of support like Medical Herstory. So I'd love to keep this conversation going. You can find out more or ask me questions on our social media or by email. You can read more about my own personal experience on our website, medicalherstory.com. Or like I said, you can check out our YouTube page where I have some talks that go more into depth about my research findings, as well as this 3-phase theoretical model that I propose in my discussion that I didn't get into today, but I encourage you to check it out. And I'm now going to pass over to my great friend Oyinko for her awesome presentation.
Okay, hi everyone. My name is Oyinkansola Ojo-Aromokudu, and my dissertation was about off-label drug use. I sat within the philosophy and ethics department of history and philosophy of science at Cambridge. So that's the approach I'm coming with today from, I guess, armchair philosophy. There's going to be lots of different approaches from anthropology, sociology, but mine is philosophy today. So as I said, it's about off-label drug use, and my research was kind of off-label drug use is something that it goes across lots of different medical specialties across the world, and it's also not talked about that often. And then the theme of today's conference, I'm going to take a feminist approach to it and consider how women specifically are affected by it. So today, I hope to leave you with 5 things. First of all, what off-label drug use is, and secondly, what evidence-based medicine is and how it relates to off-label drug use. And I guess in doing that, you'll be able to see how they're in an epistemic battle, I guess. The two don't marry up, even though doctors who say that they are practitioners of evidence-based medicine practice this off-label drug use prescribing practice. Third, we're going to go through the arguments for and against off-label drug use. Fourth, I hope to persuade you that there's reasons for the permissibility of off-label drug use. And fifth, like I said, we're going to take a feminist approach and see how women are affected specifically. Okay, off-label drug use. So what is off-label drug use? So in most developed nations, before a drug can be prescribed, it has to have been given a license by a regulatory authority before a doctor can prescribe it to a patient. And in the UK, that's looked after by the MHRA, and in the US, it's looked after by the FDA. So sometimes doctors prescribe drugs for reasons other than which has been stipulated on the label. So an off-label prescription is an instance where a drug has been prescribed for an express purpose of treating a different disease at a different dosage or for a different demographic than approved by the regulatory authority. So for example, if you have, this is just like a standard medicine Nurofen here, inside of it you have the medicine itself, and then you have the label. This is what I'm referring to as the label. It's the document inside the box. Or if you have like a bottle here, sometimes you have like peel off, and this document inside here is the label. So that's what I'm referring to as the label. So the label stipulates that the drug is able to be sold at a particular jurisdiction, in a particular jurisdiction, at a particular dose, to a specific age, and for a specific duration. And it's important to note that off-label drug use is not illegal and doesn't automatically imply unsafe or improper use or bad medicine off the bat. So to understand it a bit more, we're going to move into evidence-based medicine and look at what evidence-based medicine says about off-label drug use and how the two are opposed. So evidence-based medicine is a philosophical school of thoughts within medicine more generally, pioneered by David Sackett in the late 20th century. And in short, evidence-based medicine is married to evidence. So clinicians and academics look for evidence before they make a clinical judgment or clinical decision. And off-label drug use is interesting philosophically because it is opposed or operates outside of that expectation of evidence-based medicine. So here on the screen, there's the evidence hierarchy. And at the core of it, it's just an evidence hierarchy that ranks evidence in order of which it should be deferred to, according to how it can be affected by bias, where bias is a result of an aspect of a study which makes the conclusions that are derived from that study incorrect. So the hierarchy serves as a measure of reliability, and evidence-based medicine in general strives towards objectivity. So typically at the top of the ladder, you have randomized controlled trials. The meta-analysis and systematic reviews just means the summary of many different randomized controlled trials. And then lower down, you have non-randomized cohort and case control studies. And towards the bottom are anecdotal case reports and expert opinion. So there's a clear clinical ideal here, which is for the randomized controlled trial, which is considered to be the gold standard of evidence in evidence-based medicine. So going a bit deeper into the randomized controlled trial. So an RCT is a study designed or devised to compare interventions. So the randomized controlled trials are lauded for their random allocation of subjects. So participants are randomly divided into two groups. So you have the experimental group here and the control group. And the experimental group are given the experimental treatment, these guys here, and then the control group are given the standard treatment that you're trying to measure the experimental treatment against, or a placebo, which I'll get into later. So variables of each participant are recorded and measured so that when each group is randomly allocated, we can be sufficiently, the two groups are sufficiently similar to reduce bias and increase confidence in the conclusion that the intervention was the variable that caused the difference in outcome at the end of the trial. So parameters relevant to the ongoing trial, for example, blood pressure in a trial testing an antihypertensive drug, for example, are measured before, during, and after the trial. And after, the inference can be made that it was the intervention that caused the difference. So why is randomization important? So randomizing allocation between groups supposedly allows for the possibility of controlling, as I said, for the known variables, making the two groups as similar as possible. And that if there are any differences, these are due to chance and not any deliberate action. So it allows researchers to circumvent selection bias, where if the participants or if the clinicians themselves were able to choose who goes into what group, then they might subconsciously choose the sicker people to go into the experimental group or vice versa. And in a blind trial, the participants themselves, these guys over here, don't know which group they have been put into. And in a double-blind trial, the participants and the clinicians or the researchers looking after the trial also don't know. Everybody is just as blind as the next person. So looking a bit deeper into the randomized controlled trial and into the clinical licensing procedure as well. As I said, the experimental group get the experimental drug, and the control group get the standard treatment or placebo. And a placebo is an inert substance that looks just like the experimental substance, but it's inert, so there's no physiological impact to the patient or benefit to the patient. So in terms of the clinical licensing procedure, a drug passes through a series of clinical trials before the regulator or the regulatory authority considers it for approval. So the first trials are called phase 1 trials, and this is the first time that the drug is tested on humans in a clinic. And this typically includes a small number of healthy people, and researchers are concerned with significant safety issues arising from the drug at that point. And phase 2 trials are RCTs, as we've described in the last couple of slides. So phase 2 trials are conducted on a larger population where people, not always, but usually have the condition that the whole trial is set up to investigate. And researchers are concerned here with the effectiveness of the treatments and experimentation with dosage levels during the phase 2 trials. And the phase 3 trials are the most important trials with regard to clinical licensing procedure, as the regulators in the UK and in the US require drug companies to provide at least 2 successful phase 3 trial studies, so to present their findings to the regulator. So these phase 3 trials involve between hundreds and thousands of participants. And if the regulator is satisfied with how the trials have gone on, then the regulator can then decide on how the drug is going to be labeled in that country, in that jurisdiction. So here I have just a blow up of a label. This is a label of Tylenol. Tylenol is the same drug as paracetamol in the UK. It has the same active ingredient. And here you can see that there are 7 areas which a drug label includes. So you've got drug facts, uses, warnings, directions, other information, inactive ingredients, questions or comments. And I just want to draw our attention to two of these areas. So the first is the uses. So here the label lists the conditions that this drug, Tylenol or paracetamol, has been licensed to treat. So you've got the common cold, headache, backache, toothache, muscular pains, etc. So if somebody is using this drug to treat anything else other than what has been labeled here, that is considered to be an off-label use of the drug. So I hope that just gives some more context about what an off-label drug use is. And then here you've got the directions, which shows how much of the drug to take, how often, and by who. So if anybody, or if a doctor prescribes a drug for anything outside of what is written in this box, that is also considered to be an off-label use of a drug. Okay, so getting more into the philosophy of it, we're going to look at the, I guess, for and against. But before that, just to, I guess, understand how widespread the prescribing practice is, it's quite difficult to ascertain exactly how many off-label prescriptions are written, whether in the UK or in the US or anywhere in the world, because there's no centralized body that looks specifically at this prescribing practice. It's very ad hoc, and prescriptions are written at the level of the individual clinical encounter. And there are a few large-scale national or international studies that look specifically at this, like I said. But there are a few studies, and I just want to bring our attention to a couple. So there is a study that estimates that 1 in every 5 prescriptions written in the US in US clinicians' offices are off-label, and another estimates that about 50% of all prescriptions written in the US are for off-label purposes. And this estimate increases to 75% of prescriptions written in a specialty of oncology, and that's where prescriptions are written to treat cancers. But off-label drug use is also prevalent in pediatrics, with a study estimating that about 54% of all pediatric prescriptions written in the US in 2014 were for off-label purposes. So we've got a couple of, I guess, arguments against off-label drug use or concerns about off-label drug use. And the first is that off-label drug use is a problematic practice for evidence-based medicine because the clinical judgments and actions that are made using evidence that is not vindicated by an RCT. And as we've seen earlier, an RCT is the highest form of evidence in evidence-based medicine. Secondly, there seems to be a lack of attention to safety and a kind of subversion of drug safety and efficacy to be fully evaluated when doing off-label drug use. Thirdly, regulators have no control over how doctors choose to prescribe these drugs to their patients. That's the same in the US and in the UK. In the UK, there's a body called the GMC, the General Medical Council, that looks after doctors in the UK and keeps everybody on the straight and narrow. And they, on their website, say that doctors are able to prescribe medicines as they see fit, depending on that particular individual circumstance. They have no authority on telling doctors to prescribe this as opposed to that. You can find out more about that on their website. And finally, there's no visible, consistent framework regarding how doctors are prescribing. So one doctor can prescribe off-label for this reason, but that framework is not going to be the same for a different doctor in a different scenario with a different patient. So it's all pretty ad hoc. So those are some of the concerns that people might have about off-label drug use. But what does off-label drug use have to say, or how does it justify itself? And the first thing would be about the limitations of RCTs. So RCTs are prone to error. Bias can still enter the trial despite blinding the trial and despite randomization. Two groups can still be impacted by a compounding factor even after randomization. So a trial can never be balanced with respect to all variables, and therefore the conclusion from an RCT will always be inference based on insufficient data. Also, limitations can arise from how people are recruited into the trial and the resulting test population. And that means that subjects that end up being involved in a clinical trial usually end up being a narrow population set, which makes the inferences made from that set prone to error. So this causes larger problems at a larger scale when you're extrapolating from that test set into the real world. So for example, RCTs often exclude pregnant women and disabled people whilst overrepresenting other communities. Secondly, we've got mechanistic reasoning. So as a very topical example with COVID, mechanistic reasoning has also informed some off-label responses to the current situation, including remdesivir, an interesting drug to scientists at this time, because through various scientific mechanisms, it decreases viral RNA production that could prove important to developing a cure. And another way that mechanistic reasoning works is in pediatrics that I mentioned before. Sometimes, there's lots of arguments that children are little adults, and so halving the dosage for that child should have the desired effect, but just at a lesser dosage. So that's mechanistic reasoning, moving from one system of mechanisms to another. Thirdly, we've got real people walking every day. So clinical trials are not granular enough to show the idiosyncrasies of people that walk into the clinics every day. So doctors are asked, and we expect them to transpose theory onto a live case in the clinic, and there's no way that they will match perfectly, and so they innovate to account for these gaps. Fourth, we've got EBM does not converse with ethics. It doesn't make ethical statements. EBM gives us a rubric, but doesn't tell us what we should do. What would concerned voices say in cases where there is no RCT or there is no evidence and everything is novel? Should a doctor prescribe nothing and do nothing? What are we supposed to do in the absence of an RCT? Should the absence of a coherent approach from evidence-based medicine stem efforts to care? And obviously doctors don't think that it should, seeing as the rates of evidence of off-label drug use are so high. Next, we've got leeway in medicine. So there is a necessity for a leeway in medicine for doctors to prescribe creatively and progress the profession forward. And last, we have different goals. So the goals of clinical medicine on one hand, which are benefiting the individual patient, are not the goals of clinical research, which is the statistical understanding of outcomes and averages and understanding causal inferences. The two goals are different. They're not focused on the same idea. So because clinical research provides statements of fact and clinical practice provides statements of value. So as a disclaimer, just to be clear, the argument is not that off-label drug use should always be the first port of call or that it's appropriate in all circumstances, but just to bring our attention to why it might be warranted. So moving on to women, as I promised. So here we're going to look at how women specifically are impacted in prescribing practices in general, and then also specifically off-label drug use. So the first example I have here is the fen-phen incident of the 1990s. So fen-phen was a combination of two drugs, fenfluramine and phentermine, which were each approved individually in the US, first in 1973, one in 1973 and the other in 1959. In the 1990s, there emerged anecdotal evidence that a combination of these drugs led to rapid weight loss, and many doctors in the US began to prescribe the fen-phen combination off-label, so it became a compound drug together. In 1997, research found that several people who had taken the combination had developed heart valve disease linked to this drug. The drug manufacturers themselves estimated that about 45,000 people were harmed. And critics cite the lack of RCTs of the new compound drug as being the major cause of the health hazard that was inflicted on those who took it. So moving on to breastfeeding and pregnancy. So the dynamics of the female population can make consistent on-label drug use very difficult, as individuals may move from on-label to off-label users as they enter into a different age bracket or become pregnant or start to breastfeed, for which it is difficult to get a license for a drug because of the restrictions surrounding recruitment for clinical trials. So in some cases, the drugs are tested on non-pregnant adults or in pregnant animals, and then that data is then extrapolated to the population of pregnant human women. So just because it's more complex to do RCTs, including women, doesn't mean that we shouldn't do them at all. And arguably what is going on now is even more dangerous because people take more risks when they're taking medicine and begin to self-medicate. And finally, just being female presents a whole host of problems in current prescribing practices. This leads us to conversations around gendered medicine, which have only gained traction in the last couple of decades or so. And there's lots of research now going on in sex differences in pharmacokinetics and sex-based differences in drug activity, which brings out the fact that the male body has long been considered the default body in medicine, but there are differences in the sexes that warrant different approaches and treatments. So, for example, women experience heart attacks completely differently to men. Women have faster and stronger immune systems to men, but are more likely to have autoimmune diseases like rheumatoid arthritis. So there are now calls for men and women to be separated in trials for every drug, because there's a clinical difference in the way that the male body and the female body function. So off-label drug use just serves as another avenue where women are hard done by prescribing practices, and that needs more of our attention, as this has perpetuated a medical system, quote, which from root to tip is systematically discriminating against women. And that's from Caroline Criado Perez in 2019, who wrote the book Invisible Women. So that's it. So that's the 5 things. So hopefully you should be able to define off-label drug use, understand evidence-based medicine, and understand how it's opposed to off-label drug use. The arguments for and against off-label drug use. Hopefully I've persuaded you that there are reasons why off-label drug use might be warranted, particularly in the context of the clinical realities of what doctors have to do every day. And 5th, how women specifically are impacted by prescribing practices and off-label drug use in particular. So that's me. If you want to know anything more about it, please feel free to get in touch. If you want to know the sources that I use, the referencing, or just keep the conversation going, I'll be more than happy to. But thank you.
So hello, my name's Ella Monkcom, and thank you to everybody else who's already spoken. The talks are so interesting. So I'm also an MPhil student in health, medicine and society, and my undergrad was also at Cambridge, so I did human, social and political science undergrad. So I'm kind of quite specifically a sociologist, and I tend to do interviews with people about experiences relating to kind of parenting and reproductive health, and that's men and women, but this piece of work was about breastfeeding. So my work was interviewing breastfeeding women who had experienced pain. So my title is a quote there from one of the interviewees. It was a mental struggle of, I want to do this, but I don't want to do this. So to begin, when I say the word breastfeeding to you, you probably have images something like this. So especially in the West, often white, often attractive young women, kind of making eye contact with their babies. It's a really kind of intimate, nurturing, calm activity. You may also have images from other parts of the world where breastfeeding is potentially more common. Alternatively, when I say the phrase childbirth to you, you probably have images something more like this. So you have a woman in intense pain, like screaming and swearing. You have babies kind of covered in gunk, also screaming, lots of medical staff. You may also have kind of C-sections and other kinds of assisted birth in your head. So very, very different to the breastfeeding imagery. What might therefore surprise you is this quote that I had from one of my interviews this year. I'd go through childbirth again tomorrow, but I never want to learn to breastfeed again. So this was something I actually heard quite a lot, that women told me that breastfeeding had been potentially more painful than childbirth, or at least much more difficult than childbirth, which is kind of not the standard view of breastfeeding we tend to have. So I'm just going to talk you through my research and the kind of journey I went on very, very briefly, and kind of expand on this idea of why are things potentially much more different for some women than we usually think. So to begin, the stats. So this is the UK statistics. Just so I can kind of mention briefly the US statistics, because I know a lot of the viewers will be, but it's reasonably similar environment. So the UK, like the US, follows WHO guidelines on breastfeeding. So that basically says that people should be breastfeeding for 6 months exclusively, so not using any formula. And then about 6 months, they should introduce soft foods, and then they should be breastfeeding for 2 years or beyond. So some people breastfeed for a very long time. You have it's known as full-term breastfeeding, and that can be up to children aged 6, 7, 8. So in the UK, that's actually very, very, very rare. So actually, less than 1% of British women follow these regulations. Around a third of women are still giving some breast milk at month 6. But as I say, less than 1% are doing that exclusively without formula and things. So what we do know is that about 90% of British women say they give up breastfeeding before they want to. I think the conversation would be very, very different if high numbers of women were saying they were happy giving up. but there's clearly something going on that women are wanting to breastfeed. That's kind of one finding in itself, and that they're not able to for some reason. So what it means is that the UK has one of the lowest breastfeeding rates in the world. So it's lower than the US, which a couple of my American interviewees were not aware of, actually. So why should we care about the UK's low breastfeeding rate and low breastfeeding rates generally? The first thing that probably comes into your head are the potential health benefits of breastfeeding. So this is a very classic poster. This is obviously American. Benefits associated with mums who breastfeed: reduced risk of breast cancer, reduced risk of ovarian cancer, high blood pressure and type 2 diabetes. There are also lots of kind of corresponding benefits for babies, so equally reduced risk of diabetes, rare childhood cancers, and things like asthma. These findings have been reproduced in studies over and over and over again for the last 40 or 50 years. I'm not going to go into it today, but there are also lots of kind of complexities about some of this scientific research, which is kind of a whole presentation in itself. But we do know that people that breastfeed tend to be well educated, they tend to be middle class, and therefore there's probably a lot of confounding factors in those people's lives that are influencing their health outcomes. So it's potentially a lot more complicated than is usually presented, but the important thing to know is that it's generally recognised that breastfeeding has some kind of health benefits for mother and infant. So that's by scientists and policymakers, importantly. So this has had a huge knock-on effect in terms of the kind of research that people in all sorts of different fields are undertaking. The vast majority of research in breastfeeding is about how to increase breastfeeding rates. So we're coming at it from this perspective that breastfeeding is the best way to feed a baby. It's much better than formula feeding. And therefore, why aren't women breastfeeding? And that's usually with a focus on external things like the amount of support they're getting, the amount of funding breastfeeding programs are getting. And then how can we increase those things? So this is a perfect example of a kind of standard piece of research into breastfeeding. So this is commissioned by UNICEF and it's for the British government. Preventing disease and saving resources, the potential contribution of increasing breastfeeding rates in the UK. So everything is very much focusing on the science of breastfeeding, focusing on how we can increase breastfeeding rates. I don't have issue with this, and it's definitely not my intention to kind of undermine those narratives. But my main argument is that's only one side of the story, and there's a lot of other things going on to do with infant feeding, which I'm hopefully going to illustrate for you today, which are just almost never acknowledged. So I want to kind of focus on an area of research that hasn't got a lot of attention, which is how women experience breastfeeding. So generally, we've been so focused on we need to increase breastfeeding rates that we haven't really asked women what breastfeeding is like and if there might be reasons that they don't want to do it. So very, very briefly, my research. So I undertook semi-structured interviews with 22 women. As I say, they were British, but a couple had actually migrated to the UK from the US and other places. These women were recruited online and through snowball sampling. So that's when you ask somebody if they know somebody else who might want to be interviewed. The interviews were conducted in person and through online video calling. So they were about half an hour to an hour and a half, so 45-minute average. And all of the women I spoke to continued to breastfeed through pain. That's quite an important thing, I think, that we know in the UK around 62% of women have pain during breastfeeding. So that's a huge, huge number of women. But only about 10 to 20% say they stop explicitly for that reason. So we have this kind of 40%, say, of women in the UK who are having pain at some point but are not giving up breastfeeding. So that was sort of what I ended up looking at. So I'm just going to talk through some of the results I had. I'm going to do it really, really quickly, and there's not a lot on the PowerPoint, I'm afraid. It's mainly just hearing me talk. I'm just going to run through some of the quotes that I had from interviewees because I think they're quite interesting, and it's important to kind of connect with what these women were saying. It's sort of relating to what Tori was talking about earlier. So a couple of the quotes are quite extreme and graphic, so apologies for that, but I didn't want to sanitize the language. So the first theme I found was about experiencing pain. So the women who'd had pain during breastfeeding that I spoke to kind of sat along a huge kind of number line of lots of different experiences. So some people said, I didn't have a bad experience, it was a bit sore for a few days and it resolved on its own. For example, Jennifer said, it was 2 out of 10, not much at all. Much more common though was women who had had a truly awful experience. They used language like horrific, toe curling, and they kind of told me that breastfeeding pain had really interrupted their lives. Some women said they were breastfeeding for up to 15 hours a day in the first few weeks, so this was a huge portion of their time. So Charlotte said, I felt like I wanted to vomit at times, it was so excruciating. Yeah, I just remember grabbing fistfuls of my hair and just pulling it, and just wanting another part of my body to suffer more than my nipples did. So the women I spoke to used very similar language to describe their pain, which was really interesting. I can't go into it too much now because of time, but they tended to use similes. So that's saying something is like something else. And they tended to use 3 different types of similes. So the first was saying that breastfeeding pain was like fire or burning. The second was saying that breastfeeding pain was like clamping or extreme pressure applied to the breast. And the third group described it as like the nipple being cut, sliced, or shredded. So it was very kind of evocative language, quite extreme language. And some of the women I spoke to had been hospitalized for breastfeeding related reasons and had been in pain for several months up to a year. So these are quite serious injuries, some of them, but there was variation, as I say. The second theme was what women expected. So I don't know if this is the case for everybody watching, but especially those who aren't parents like me, I was very surprised by how severe some of these experiences are, considering how common breastfeeding is, considering so many people have children. And most of the women I spoke to were also really shocked. So it was very common for women to say to me, I didn't expect it because it's natural. Breastfeeding is natural, so why does it hurt? So Orla said, it is an instinctive thing. And why would it, Naturally, why would it hurt that much? It doesn't make any sense. Like, it doesn't make evolutionary sense for it to be a super painful thing. I had just thought that it would be, he'd instinctively know how to go on and it wouldn't hurt. One of my interviewees made the interesting point that we don't expect childbirth to be painless just because that's natural. So there's clearly something going on about seeing breastfeeding as natural in a different way to we see other things. All of the women I spoke to had been to antenatal classes. I don't know if that's the same language in the US, but classes before, while you're pregnant. And several of them had just never heard pain mentioned, even though breastfeeding had been discussed. Georgina said, I went on a breastfeeding course and nowhere in that did they ever say to get you ready for how painful it was going to be. Even for the women that had heard a little bit about pain, they were often still woefully unprepared. So Florence said, you think, yeah, I know it's going to be hard, but then when you're in it, it's like a different level of hardness. So the third theme that I identified was about doing it wrong. So this is a slightly more complicated one, but basically women tended to get 2 messages from other people about breastfeeding pain. So the first message was that breastfeeding pain is normal. That may seem like a good thing because it's kind of legitimizing people's experience. This is kind of coming back to what Tori mentioned earlier. But actually, being told that your experience is normal is not always helpful. If you've been for a walk as a group and everyone has kind of achy legs, but you've got a broken leg, being told that achy legs are normal is not necessarily helpful for you. So while some of the women had issues that resolved by themselves without medical attention, they were fine. Some of the women had to see doctors, they had to go in weeks of treatment. And therefore being told that their pain was normal was not very helpful. It was quite dismissive. So Hayley said, and basically the message I got was, well, that's breastfeeding. Not in a horrible way, but yes, it does really hurt. And you've just got to carry on and push through this bit. Alternatively, a lot of the women I spoke to were told that breastfeeding should not be painful unless you're doing it wrong. So by doing it wrong, people basically meant that the baby was attached wrong at the breast. So that's called your latch. So the latch was wrong. So Gloria explained, the whole expectation was there shouldn't be pain. And if there is, it can be easily dealt with by improving the latch. So this created this image that everything will be fine. It might be painful for a few days, but I'll work on the latch and it'll all be fine. But that was not the experience that most women had. So 6 of the 22 women I spoke to were never given any kind of diagnosis or any kind of reason why they were in pain. All of them have been told that their latch was fine. I also had women that had infections in the breast, so you can also get yeast infections when you breastfeed in your breast and in the mouth of the baby. I had women getting stabbing pains from other types of infection that were kind of not really related to latch, or very, very tangentially related to latch. So these women were left very confused why they were still in pain, even though their latch was fine. So Maria said, and they say you get all this advice saying, well, if you're doing it right, then it shouldn't hurt. But then they say your latch is fine. And you're like, but it hurts. What this ended up meaning was that most women tended to start feeling that it was their own fault, that clearly they were just failing as a mother. They were not working hard enough. They were not doing it right. Sam said, so, part of it was feeling like a bit of a failure as well. It feels like a natural thing you should be able to do. And then the final thing I'm just going to mention today is the theme of making a choice. So all of the women I spoke to decided to keep breastfeeding, as I mentioned earlier. So they did so for the kind of reasons I mentioned about, the potential health benefits of breastfeeding. A lot of them got a huge amount of enjoyment, which I think some of them found kind of confusing because they were really enjoying something that was also giving them a huge amount of pain. And they knew their baby enjoyed it. So there's a kind of maternal instinct there, if we want to call it that. And they all kind of felt that the pros of breastfeeding outweighed the cons. This created this sort of ongoing battle, because they had decided in a kind of sensible headway that they wanted to keep breastfeeding, but they had this physical aversion, and there was also a huge part of them that really kind of wanted to stay away from something that was causing pain. So Carmen said, it's really difficult to stay sane when you're expecting that pain, but are refusing to give up what's causing the pain. So I think that was it was a mental struggle of, I want to do this, but I don't want to do this. So the thing I really want to leave you with that's kind of all I have time to go through. But is basically that I think people are very quick to give opinions about breastfeeding when they don't necessarily know anything about it. I was at the gym the other day, and the instructor is pregnant, and a woman came over who has never had children and started telling her why she should breastfeed, which is absolutely fine in some ways, because a lot of people want to increase breastfeeding rates. The alternative of that is that actually this is a much more complicated field than we usually recognise, and we need to be realistic about what we're asking women to do. So if we're going to promote breastfeeding, we also need to look at what that means for these women and what the kind of time and potentially pain investment that can mean. So thank you very much for listening. I haven't put my email, I just realised, on here, but if you did want to ask any questions now, and you can always message Tori and ask for my details. So yeah, thank you very much.
Thank you so much, Ella. So we're going to move into our first question and answer panel. So if anyone has any questions for the previous panelists, you can just write it in the chat. We're going to start out with a question for, I see we're getting some questions in the chat. But the first question that we sort of wanted to highlight was, what are some of the difficulties of conducting feminist health research, whether that's in the way the research is conducted, or sort of if you have, your own experiences of what of difficulties you encountered throughout your research?
I can go first. So, I mean, like I said, my dissertation was from a philosophical standpoint, and I kind of felt out of place in philosophy. So by training, I'm an anthropologist. I did my undergraduate in anthropology, and I have been immersed in social issues from the jump. So philosophy to me felt a little bit removed, and like I said, it felt like armchair philosophy, where I wasn't really talking to anybody. I was just thinking about things in my head and looking at philosophical frameworks that I could apply to this particular problem. So in terms of feminist health research, I think that there really is a massive lack in philosophy specifically regarding that, and I really had to make a conscious decision. So my dissertation wasn't a feminist approach that I added for this presentation, and it's almost indicative of just how difficult or how unthought of it is within philosophy to consider things from a holistic point of view and to bring in like a holistic approach. It's all very male-centric. It's all very what has been done before, and people just carry on from where other people have left off.
One of the issues I have, and it's kind of like complicated whether this is or is not an issue, but in terms of trying to get a broad demographic, so women from lots of different backgrounds, and one of the things about breastfeeding, which is kind of interesting in itself, is that it's at least in the UK, and I think it's probably similar in the US, it tends to be something that middle class, often white, but you also get higher rates of breastfeeding in women who migrate into the UK rather than are British born. So, you know, obviously that includes people of all sorts of ethnic backgrounds. And it tends not to be something that more working class women do in the UK. So it would be really interesting to hear more stories about that. I suppose on the other hand, looking at this very specific demographic kind of allows us to look at how kind of ideas about like motherhood and parenting and gender do vary by in demographically. So I've been able to look kind of very specifically about kind of natural parenting and what the idea of nature means, and that's something that really varies between I haven't looked so much about different ethnic groups, but definitely by class. It's something that has very different meanings. So it's kind of a drawback, but also interesting in terms of situating you specifically.
And I think one of the major difficulties that you could draw across the three of our presentations is sort of looking at how you take a narrative that is seen as something that's positive or encouraged. So in my case, that's normalization, normalizing illness, you know. In Oyinko's case, we've got clinical trials, and then with Ella, we've got breastfeeding. And these are discourses that on a surface level, people think are positive things. So I think there's a bit of difficulty in presenting research that goes against the common narrative and sort of complicating it and subverting it in those ways. Another point I would say in my own research, there's an interesting dynamic when you are studying a population, let's say, that you also identify as. So I found that was something I had to navigate with my participants in saying from the beginning, well, we do share this similar illness, we're all going to experience it differently, and trying to prime them to explain yeast infections to someone as if they didn't have them. So that was one way to sort of get around that. But then I think there was also this assumption that when you are a researcher, you still have a certain level of expertise. Like, for example, at the end of all of my interviews, I was asked, do you know the cure? Do you have the cure for chronic yeast infections? Have you found it? You've been doing all this research, you know, you're an expert in this now. And I think it's interesting to balance those things of being both a researcher and then a patient yourself, and sadly lacking those answers that you wish you could provide.
We have one more question from the chat, and it says, thank you for the great presentations. A question about clinical trials and populations. I know from my work adjacent to the pharmaceutical industry that there's often a huge number of factors that go into populations to study in a clinical trial, most of which aren't related to clinical need. Things like what other drugs cover segments in the market, what populations are most likely to show a positive result, etc. I would assume this reasoning also often excludes women and other underserved groups from trials. Is this something you've looked at specifically?
So yeah, I agree with everything that Alex has said here. It's not something I've looked at specifically in depth, but it's something that there is a lot of research about, which I brushed over towards the end of my presentation. But this question also hints at there's lots of things at play in the pharmaceutical industry, including politics, there's big money involved, there's a lot of, you could really make a Netflix documentary about what is going on in the pharmaceutical industry, but there are some ulterior motives that companies have to get their drugs to the market. Drug companies don't really mind if their drug is being used on or off label, so long as it's being bought. And there's all sorts of things going on behind the scenes that mean that the results are skewed. And as I said, the regulator only requires the drug companies to provide 2 successful phase 3 trials, but you could have 8 unsuccessful trials, but you don't have to show those so long as you have 2 successful ones. So there's lots of things going on there. But yeah, if we can talk later on, Alex, about all this stuff, but you're right.
And we have one last question for Ella, and it says, I am postpartum right now, and I'm wondering, did you find a difference in the pain experienced with mothers who delivered via C-section versus vaginal birth, or those who had more challenging birth experiences?
Yeah, there is also another question above from Laura. I don't know if you want to do that as well, but yeah, in terms of that question, I didn't. I know there are some studies that suggest that mothers who deliver by C-section can have more trouble with breastfeeding. I'm not sure. I actually don't know whether they necessarily always suggest that it's more painful. Breastfeeding is more painful. But just things like after C-sections, you're more likely to have a longer period of time before you don't have what's known as the golden hour necessarily. They've kind of tried to push that recently. I didn't find that. There were a couple of interesting things. So the women who had, the thing is I only interviewed 22 women, so it's a small kind of cohort, but the women who had delivered by C-section I found were probably more likely to say that breastfeeding had been worse than childbirth. But I don't think that meant that their breastfeeding experience was worse. I think it was more just they hadn't necessarily been through labour to the same extent. However, I also had a lot of women say that breastfeeding was more difficult. So even though the kind of most extreme pain event they had experienced may have been breastfeeding or childbirth or labour, breastfeeding kind of presented a lot of challenges that labour doesn't necessarily. So for labour, we tend to know it's going to be painful. You tend to get pain relief. It tends to be time limited. So you know that labour is going to be over in a few hours or a few days, and then you get a baby at the end. Whereas for breastfeeding, most women didn't know it could even be painful. It's very difficult to access pain relief because that can sometimes impact your milk. And also some women had pain for up to a year. They'd resolve one infection and then a new one would come. So even if the kind of most painful event wasn't breastfeeding, it could sometimes pose more problems. Hopefully that answers that question.
Perfect. So I think that concludes the end of our first question and answer panel. Okay. Let's see. Okay, so hi, I'm Rachel. I majored in the history of science at Princeton. And at Cambridge, I also focused on the history of science. So the presentations thus far you've seen some anthropology, you've seen some sociology, but my presentation takes more of a historical lens for another issue in women's health. What is postpartum depression? So postpartum depression is a depression that women experience after childbirth. And the symptoms can range from pretty mild to severe, and it can last for a couple of days, weeks, or months. Now, some women feel tired and anxious, while other women completely reject their babies and feel that they can't care for them. Today, the National Health Service estimates that 1 in 10 women suffer from postpartum depression. But even today, medical professionals can't really conclusively determine what causes postpartum depression. Some hypothesize that it's caused by a change in hormones after a woman gives birth, such as the sudden decrease in progesterone after a woman delivers her placenta, while other researchers claim that women who lack social support, whether that's in the form of maternity leave or a supportive partner, are at a greater risk for developing postpartum depression. And lastly, some say that postpartum depression is caused by psychological triggers, such as pre-existing traumas or feelings of insufficiency surrounding motherhood. So though there have been accounts of madness in mothers since the time of Hippocrates, postpartum depression was only added to the Diagnostic and Statistical Manual in 1996, which is like the definitive psychiatric classification system. And it didn't really receive any considerable attention until the 1980s. So my dissertation examined the medicalization story of postpartum depression, or the process by which it came to be recognized as an official medical condition. And I focused mainly on the 1980s as the crucial turning point in this story. Now, often sociologists critique medicalization as a means for the medical industrial establishment to exert social control over populations, like taking a normal condition and framing it in medical terms. So suddenly, if you're short, you need, human growth hormone to treat that. But when we look at the story and the history of postpartum depression, we see that medical professionals and the women who were suffering from the disease worked together and collaborated to bring more medical attention to postpartum depression, and they simultaneously pushed for more social understandings of the disease. And I argue that because postpartum depression lacked a definition for so long, it allowed these different stakeholders to come forward and proffer forth their own definitions. So my research really focuses on the psychological, biological, and social theories of postpartum depression. So before we jump into the 1980s, it's useful to understand sort of how people were thinking about mental health and women's mental health in the post-war period in Britain. So after World War II, medical professionals increasingly recognized mental health as something that was important, especially after so many people suffered anxiety as a result of the war. Psychoanalysis became incredibly prominent. And as British society worried about the next generation of future citizens, they started to look towards mothers. And they worried about how mothering would affect the next generation of British citizens. So prominent psychiatrists such as John Bowlby developed theories of maternal attachment, which claimed that mothers who didn't properly love her child could cause them psychological maldevelopment later in their lives. So medical professionals began worrying about how distressed mothers could negatively impact their children. And they emphasized the importance of the mother-baby bond after childbirth. And these ideas also were heavily influenced by Freud. So while we see a rise in the interest in sadness in mothers, doctors don't really have a clear understanding of its causes, and they often framed it as, the baby blues or something that was temporary and would go away. And women were encouraged not only to ensure that they wouldn't negatively impact their children, but also so that they could resume their homemaking and mothering duties. And there was no formal diagnosis or access to medication. So throughout the 1960s and 1970s, many psychoanalysts influenced by Freud began describing how childhood traumas or feelings of guilt over being an imperfect mother could cause postpartum depression. And in light of these theories, really until the 1980s, the dominant mode of treatment for postpartum depression was psychotherapy as a way to work through these deep-rooted traumas. So for example, in 1970, one woman described that when she went to her psychiatrist about feeling depressed after giving birth, he suggested that she may have lesbian tendencies or that she hated her mother and father, and that's what was causing her depression, and that psychotherapy could help them work through it together. Also in the 1960s and 1970s, we see that there were a lot of mother-baby units developed in England. Now, a mother-baby unit they were psychiatric units where a mother who suffered from postpartum depression or psychosis could be treated while remaining united with her baby. And families often took part in the psychotherapeutic process, but this remained the dominant form of treatment really up until the 1980s. The greatest shift we see really began in the 1980s when biological psychiatry sort of starts to come in vogue and people start to become more skeptical of Freud's psychotherapy and, all of the issues that come along with that. And there were a lot of successful chemical treatments to mental illness during that time. For example, selective serotonin reuptake inhibitors, or SSRIs, were developed, and they were widely used as antidepressants. So in Britain specifically, a lot of psychiatrists became interested in framing postpartum depression as a biological disease. They formed a research group called the Marseille Society in 1980, and they promoted these biological understandings of postpartum depression, like the theory that the sudden drop in progesterone after childbirth would cause depression. And they encouraged the use of antidepressants. They encouraged hormone patch therapies, and they were widely at odds with the analysts who encouraged more talk therapy. So while we begin to see the increased medicalization of postpartum depression, both those who espoused psychological theories and those who espoused more biological theories, postpartum depression really started to gain attention from the media and society when women themselves began advocating to recognize postpartum depression more formally. They began to push for new understandings and one that considered biology along with social factors. So the National Childbirth Trust, which is the largest parenting charity in Britain, which was established in 1956, they began advocating for more resources for women suffering from postpartum depression in the 1980s. Now, to understand why the 1980s, it's important for a little historical context. Mothers were entering the workforce at record numbers in the 1980s, and all of a sudden you have society encouraging women to maximize their usefulness in the public sphere, while at the same time providing unconditional love and sacrifice for their children in the private sphere, which was, leading to additional stresses on mothers. And feminists began writing about how society's unreasonable expectations of mothers and the lack of social support caused postpartum depression. But at the same time, the 80s, we also see the rise of self-help groups, which is a little different than the more formalized organizations like the National Childbirth Trust. And these were grassroots organizations of women who began organizing into local groups to provide support for other women, whether that was through a coffee chat, through a phone call, just reaching out. And the first one was established in 1979, and it was called the Association for Postnatal Illness. It's still in operation today. But while they recognized the value of social support, they also really tried to frame postpartum depression as a medical condition. They wanted the National Health Service to do a better job at helping women get connected to psychiatrists, and they wanted general practitioners to be better equipped at recognizing and diagnosing postpartum depression early on. And they specifically partnered with doctors from the Marseille Society to push for this increased medical recognition. Now, this campaign differed from previous feminist health groups who believed doctors tried to control women when they medicalized the conditions that affected them. So, for example, in the 1970s, feminists argued against framing premenstrual syndrome as a medical condition because they believed it reduced women to the biology of their diseases and it placed the locus of blame for the disease on the women themselves. But these self-help groups, on the other hand, for postpartum depression, they published pamphlets and they spoke at conferences to really go into the biological roots of the disease. They explicitly sought the help of the medical profession, and they thought this would help women feel that they were not alone, and so that women didn't feel that postpartum depression was a personal failure. So when we think about the long-term impacts of this medicalization story, it's really important to think about how postpartum depression was conceived in the 1990s onwards. So as I mentioned, in 1996, the Diagnostic and Statistical Manual added postpartum depression as a course modifier, largely as a result of the campaigns of psychiatrists and feminist advocates working together to really bring more recognition to the condition. Also, the media began a lot more widespread reporting on women's narratives with the disease. So after Princess Diana in 1995, after she came out with her narrative that she had experienced postpartum depression, tons and tons of women began writing in with their own stories, and a lot of these narratives were brought to the forefront. So we begin to see that postpartum depression is taken more seriously as a medical condition, but we also see more nuanced conversations surrounding the condition in general. As I described also in the beginning, we still don't know what causes postpartum depression. And that's what makes this medicalization story so complicated, is that we don't really have consensus. But it's precisely because this definition has remained so elusive that different stakeholders were really able to come in and give their own definitions and theories. And when we look at the history of postpartum depression, we see that various social actors, whether that was the psychoanalysts, the Marseille Society, or the feminist advocates, were able to give biological, social, and psychological explanations of the disease. This historical understanding is really crucial, especially as we look to how to best support women today in medical practice. We need to continue considering interdisciplinary approaches to help achieve more nuanced treatments for women. We can offer them self-help, we can offer them antidepressants, we can offer psychological therapy, but at the same time, we also need to continue thinking about health policy and thinking about how to improve our social policies to support mothers, like more generous maternity leave. So postpartum depression, as it always has been, remains a disease in construction and one that we have a responsibility to address. And thank you so much for listening. I also did not provide my email, but you can message me or email me if you have any more questions about this.
Thank you very much to Tori for organising this, and also to Rachel for her presentation, which I think leads on really nicely into mine. So I'm also an MPhil student in Health, Medicine and Society, and my background is in medicine. I'm a doctor currently working in sexual health, and I also have a background in public health. This year I focus a little bit on philosophy of public health, but for my dissertation I was looking at gestational diabetes. So it was based in medical sociology, and specifically I was looking at patient community and gestational diabetes. So it builds on a lot of what Rachel's already discussed about kind of communities and the ways in which groups of women experiencing particular illnesses have shaped the way in which they're seen and treated by medical professions, and also kind of the sort of social world at large as well. So the title of this, What to Expect When You're Expecting a Sugar Baby, comes out of the fact that women in this group refer to their babies as sugar babies. And What to Expect When You're Expecting is obviously the kind of very famous pregnancy self-help manual. So it's kind of getting at those ideas of self-help and patient community. So a little bit of background about gestational diabetes. Gestational diabetes is a form of diabetes that occurs in pregnancy and usually resolves after pregnancy, but it carries an increased risk of type 2 diabetes for both the mother and also the child. It's treated through medication, so that can be metformin, tablets, or insulin, and also very rigorous self-monitoring. So this here is a glucometer which women use to check their blood sugar after each meal. Because of the fact that gestational diabetes carries a number of risks, which include the risk of stillbirth, the risk of neonatal hypoglycemia, so neonatal low blood sugar, which can then cause developmental issues, and also the risk of miscarriage. Women who have gestational diabetes are generally referred to as having a high-risk pregnancy. So they kind of get a lot of extra intervention, a lot of extra monitoring, and often are directed into certain pathways of care. So for example, they might find it difficult to give birth at home and would be advised that they have to give birth in hospital instead. So a bit of the background of previous research in gestational diabetes and kind of my ideas in moving forward with this. So a lot of the previous GD research builds on earlier feminist research, which Rachel's already alluded to, about medicalization and pregnancy. So The Captured Womb is a book by Anne Oakley, a historian and sociologist, about the idea that increasingly the medical care of pregnant women became more and more medicalized, so more intervention, more scanning, more screening, more people present at the birth. And a lot of it has critiqued that as being a way that women's bodies are controlled, that pregnancy comes under increasing scrutiny, and that having negative effects for women. So the research into GD emphasizes this sense of guilt, of sacrifice, and of scrutiny. So women feel guilty about having GD. They feel that they need to work hard to make sacrifices and do anything they can to avoid some of those risks like stillbirth and miscarriage. And also feel that they're scrutinized by their doctors, so that they're being watched, that they're being sort of regulated and tracked by their healthcare professionals, and that has quite a heavy psychological burden on them. There's also this sense, not just in diabetes, but kind of looking more broadly to chronic illness, that increasingly there's this real emphasis on self-management of conditions. So the idea of the patient as the expert, the patient learning how best to manage their condition. And that kind of comes out more broadly when we think about things like obesity and the idea that we should be working on our weight, we should be making sure to exercise. There have been lots of critiques of that, these practices of self-management. So previous researchers in GD have argued that women who have GD are encouraged to basically, they're disciplined, but also they're playing the role of the disciplinarians, that they're tracking their progress. And so there's an imposition from doctors for women themselves to become, you know, the watchful keepers of their own health. What's really missing though in GD research is any ideas of community. So as we've already discussed about ideas of community in postpartum depression, there seems to be really little research out there about sort of how women with gestational diabetes have related and interacted with one another. So just a bit about my methods. I originally set out to look at the idea of risk and responsibility in gestational diabetes. And I was using a methodology called constructivist grounded theory. And the idea of that is that the findings of any research project aren't discovered, they're not out there existing in the world independently, but they're constructed, so that my role as a researcher is crucial in creating the data that I did. And the idea is that you go into the field without too many predefined hypotheses or things that you want to test. And this was the case for me in the sense that I started off just wanting to look at risk and responsibility, recruited some women through this community group, which I'll go on to talk about. And the first few interviews, they all said how important it had been. So my research project then shifted actually to focus much more specifically on this particular group and the impact it had had on these women's pregnancies. So I did interviews with 18 women from this community group, which I called GD Mums. So they were fairly lengthy interviews and were a narrative interview. So I just asked women to tell me their story and then would kind of ask more questions as I went along. In keeping with the grounded theory, I did what was called constant comparative method, which is where you get your data and you start analyzing it even whilst you're doing interviews. So unlike maybe more quantitative research where, you know, you can't change the methods midway through because that would create bias, the idea is that I spoke to women and they said things which I then brought up in later interviews with other people. So a brief background to GD Mums. This is a picture from their Instagram. It was founded by a woman who I call Sam, who has 3 pregnancies, had 3 children, and all of them were pregnancies with gestational diabetes. So she set up what was originally a private Facebook group, which now has about 12,000 members. And there are also offshoots. So there's a website which contains a lot of dietary advice, as well as tips about sort of, living with GD and birth, and also after birth as well. And there's also a Facebook page and an Instagram. It's entirely community funded, so it's not got any corporate backing or from organizations or charities. It's just funded by memberships that women pay to access premium recipes. And the important thing to know about GD Mums is that the dietary advice it gives diverges quite significantly to NHS and kind of the standard advice that women are given, which is usually to eat starchy, like high glycemic index carbs. GD Mums, on the other hand, advocates a very low carb diet, almost like a kind of Atkins keto type diet with high fat, high protein. And as I'll go on to discuss, this kind of becomes relevant in terms of how this plays out in the group. So I'm going to talk about my results, and the results I presented here are kind of 4 key processes that women in GD Mums engaged in. So through their participation, these are 4 things that they all did. The first was this idea of negotiating knowledge, so that when they started to follow the dietary advice that was given to them by their doctors or their midwives, lots of them found that this advice wasn't working, that their blood sugars were getting higher and higher, and they couldn't seem to keep them under control with the diet they'd been prescribed. Then they found this group which suggested this very different dietary guidelines, and they were faced with a kind of conundrum about what to do. So as Esther said, I can either follow some advice that's been given to me by a medical professional, or I can follow the advice of a group of women on the internet. One of them I know is kind of endorsed by the NHS, and one of them I get good readings. So they have this strange paradox where they're keen to follow medical advice about keeping their blood sugars low, but they're turning to women on the internet, as Esther says, as a way to do so. Over time, though, women began to see other women's experience as often more helpful than medical advice, so that the experience that other women had about coping with GD, and particularly in regards to diet, was actually seen as more helpful than their medical professional. So it kind of replaced the medical knowledge they received as being more useful. But crucially, women didn't entirely dispense with medical or scientific knowledge, and actually all of these women cared a lot about the fact that the articles on GD Mums at the website were referenced and that they were based on research. I felt a lot more comfortable reading it than I did on other websites, because Anna could so clearly see all the research articles that Sam had drawn upon to make these articles. And they were really keen to gain knowledge and actually felt that sometimes the NHS knowledge had been given, so through their interactions with their health professionals or on NHS websites, that it kind of dumbed it down a bit. And they were actually keen to find information that didn't patronize them and gave them the information that they wanted. The second process was the idea of striving for control. And so control was very important to these women, which is kind of in keeping with early research about women feeling like they need to, make sacrifices and they need to keep their condition under control in order to minimize any risks. So for Holly, she said, if I have that piece of cake, what will I go home and eat? Like, I messed up there, so I may as well mess up again. For me, it was like a mental thing. I had to stay on track. So far, all of that was fairly in keeping with previous research. But what was really interesting and kind of contradicted earlier research about, this imposition of medical control was that actually GD mums was a lot more strict than health professionals. So there were times where women had been told, oh, it's okay, you can eat, Christmas cake on Christmas Day or have a birthday cake. Women on the group themselves were saying, actually, no, that's wrong. Why would you be doing that? And as Nadia said, I think if I hadn't found this group, I would have been cooler. I would have been cooler about GD. So it's kind of like, it's a bit bittersweet, I guess. There was this idea that women were supported by the group, but also that it very much kept GD at the forefront of their minds. The third process was about navigating medicalization. So lots of women described a lack of trust in medical services. There was a sense that they were being herded through. Lots of women use similes about being pushed through like cattle. And they said that they often felt they were coming up against professionals who didn't really understand GD, who felt like they weren't able to interact with on a level that, the level that they understood. So Lily said, there's a feeling that if you've got gestational diabetes and you've read Sam's website, you'll have more knowledge and training around GD than the midwives treating everyone. So this led to a strange paradox where sometimes women felt confused by the way that they'd been treated, and sometimes came to dispute medical practice. One thing that came up a lot was the idea of NICE guidelines, which are guidelines, national guidelines for England and Wales, which are not mandatory for hospitals to follow, but it's meant to be a kind of standardized, evidence-based way of practice. And often women had learned about these through GD mums and then went to their hospitals and found that they weren't actually following those. This led to some women pushing to be seen by the consultants earlier, for example, to be tested earlier on for GD in second pregnancies, or alternatively to use guidelines as a way to say, actually, I could have a home birth or I could have a birth that was in a midwifery-led unit, even if their consultants were disputing that. As a result, this meant that women in GD mums were able to negotiate better with their healthcare professionals. And I think this quote from Sally really nicely sums it up. She says, I think that GD mums, does say, trust in what you're told, but it gives you information and tools to perhaps ask the right questions, so to understand why something is being recommended to you. And in cases where maybe the explanation isn't satisfactory or it's the hospital policy, it allows you to make an informed decision that I'd prefer to wait a bit longer, I prefer to try this. So here we can see that women start being able to exercise their own agency within their interactions with healthcare professionals as a result of all the knowledge that they've got through GD mums. And then finally, the third process was becoming a GD mum. So this was really about this idea of community formation and community building with other women who shared their same diagnosis. One really important thing I think that it did for lots of women was about reframing their perception of GD. So a lot of women felt ashamed, guilty, worried that they should have lost weight before they got pregnant, that they'd eaten the wrong diet. And through seeing other women, and particularly seeing women of sort of all shapes and sizes, that really helped women to reframe their perception of GD and start thinking more like, as Catherine said, it's not your fault, you could have eaten wonderfully healthily up to this point, it won't have made a difference. And that helped women to feel less guilty about their pregnancies going forward. It also created a sense of community, so a group of people who get that you can't switch it off. In contrast to friends and family who would often encourage women to have another biscuit or try that, or I'm sure it won't matter if you don't go on a walk after your meal, this was a group who really understood what they were going through in ways that both supported them, but as I touched upon before, also kind of reinforced that idea of staying on track and sticking to the diet. Other people's good experiences, particularly around birth, also act as positive reinforcement to sort of keep women on track, as it were. So as Faith said, looking at other women, I'm seeing how other people are doing and they have a good outcome, and I think I'm doing that, like that could be the outcome for me, and it gives me confidence. The final thing to note is that even though women pointed out that there were people there from all walks of life, that it wasn't just middle class, that there was advice, for different supermarkets, for example, they did still mention that it was overwhelmingly a white community, and this is something I'm going to touch on a little bit later. So I'm just going to discuss these findings just in relation to three kind of broader themes. So the first is the idea of knowledge and how central the sort of knowledge practices were to these women's experiences. For them, the knowledge that they gained through GD mums was a way that they could shape their birth and try and to make things closer to the ideal of what they had hoped for. So closer to the ideal, for example, of not having a cesarean or of having a birth at home. There's also this real sense of a democratization of medical knowledge, that women themselves gained scientific literacy, so they would be reading scientific articles and they would be able to speak to doctors on their terms and understand medical jargon. But it wasn't just that women kind of were consuming this knowledge and becoming, you know, well versed in medical practices. It also meant that they were actually shaping medical practice. So there were a few examples of this kind of post on the Instagram page from doctors who had worked treating patients in their everyday life, but then had got gestational diabetes themselves and had then found, having had it themselves and joining GD mums, that actually the advice they'd given other women, you know, in their practice as doctors was wrong, and this had sort of shifted their practice. So, you know, as this one says, I will be recommending the use of this fabulous resource to future patients, to be sure. And other posts by doctors also mentioned the same thing, that they had changed the way that they had treated patients with GD. The second point is about discipline and empowerment. So I've touched upon this idea of control and how important that was to women. And actually GD mums encourage this ethics of behavior. So as a woman with GD mums, you should be in control and you had to remain in control. And that was often stricter than the NHS, which I think was one of the most interesting findings. But what was also interesting is, in contrast to previous research which said either there's an imposition of medical control or that, you know, patients are encouraged to survey themselves and that's another extension of control, the women in GD mums seem to express a sense that they found this control empowering, that it wasn't that they felt pressured or unduly burdened, but that actually by working to, as they called it, stay in control, they could feel that they were being good mothers, that they had maybe got this diagnosis that they weren't expecting, but they had shifted things around. So it wasn't that they were irresponsible for having gestational diabetes, they were even more responsible as a mother because they had taken this unfortunate thing and were working extra hard to safeguard their baby. But I do think it's really important to consider this idea of empowerment and discipline in the context of wider structures. So lots of these women, as was alluded to by them themselves, were white, and even though they spoke about how it wasn't purely middle class, all of my participants were in professional and managerial jobs. And I think any discussion of sort of empowerment and self-management needs to be tempered with this idea that actually there are going to be certain groups who are more able to access these resources, who are more able to undertake these self-management practices. And finally, this idea of the ethics of self-care, so that women on GD mums came to see themselves as having an ethical responsibility for themselves, to their babies, and also to one another, and that they had a duty to help other women that they saw in the group. But more than this, I think it also reinforced their sense of entitlement to certain rights. So it also, you know, brought about this ethics of care from the doctors themselves. And this is a post from their Facebook saying, "A cry for help. 3 different ladies have posted in my group today are sitting with high blood sugar levels and being told this is fine by their teams. This is not fine." And I think this is a really interesting example of the way the group helped to highlight to women the gaps in their care, the fact that the NHS advice was wrong, the fact that they were often being shunted from person to person without any continuity, and helped women reinforce upon women that actually GD was a condition that was worthy of more medical attention. So just to sum up, I kind of made 3 key points in the work that I've done. Firstly, it was a novel analysis of community and GD. So to my knowledge, there hasn't been anything on this before. And I made 3 arguments. Firstly, that GD mums wasn't just a space for support, although that was certainly the case too, but it was also a space where women would make claims about how to manage GD, would sort of dispute medical claims that they'd heard before, and also to, you know, come up with new claims themselves. Secondly, that the strict practices of self-management that they engaged in were not entirely imposed by the doctors or the midwives that they'd seen, but were actually fostered and reinforced by their interactions with one another on the group. And finally, that these social interactions with each other engendered a new form of activism in which they reframed GD as a shared and collective experience that was deserving of more medical attention. So I guess the overall argument of this work is the idea that women can invite, contest, and negotiate the medicalization of their pregnancies in ways that are sometimes contradictory, in ways that are sometimes overlapping. And I think this quote by Raina Rapp, who's an anthropologist writing a long time ago now, really sums this up. That we must also insist on the potentially liberatory nature of a feminist science, one which assumes that women might want something more from reproductive technology than to get it off our backs. Great, thank you very much.
So thank you guys for having me. It's really an honor to present for Medical Herstory. So like the wonderful presenters before me, I was in the same master's program. I focused on medical anthropology. My background and my work focuses around migrant and minority health. And if you need to reach me, you can reach me at this email. I'm currently a medical student at the University of Texas at Austin. So this is my new institutional email. So when I submitted the presentation for this title, I didn't realize at the time, but now I look back and I think that it's actually pretty vague and barely scratches the surface of what I'll be talking about today. It undermines the really complex embodiment and trauma of the lived experiences from the people at the market that I will discuss, and specifically how trauma can be sustained in vulnerable populations through hierarchical power dynamics and structures, both physical and symbolic. So I hadn't approached this research initially with a gender lens, and I definitely acknowledge my limitations and expertise and being a male. But at this market, most of the migrant workers are women, and the resistance movement against the gentrification is entirely led by women. Moreover, we know that issues of class and race already disproportionately affect women as is. So in this presentation, I push an intersectional lens to address the effects of this gentrification that we'll talk about. This market is in North London, and it's known as the Seven Sisters Indoor Market, or colloquially Pueblito Paisa, which is in Spanish has been translated to the Latin village. So when you walk into this market, it literally feels like you're not in London anymore. It's really akin to Latin America. The smells, the orders, you only hear Spanish, the food. Actually, all of the workers in the market are BME, which stands for Black and Minority Ethnic, and almost all are either migrants or children of migrants. Now, when I use the word migrant, I know sometimes this can be a little reductive, but for the purposes of the presentation, I will use it. However, it can encompass all forms of displacement from a previous location, which includes forced or not. And actually, many of the migrant workers are refugees who had fled political or economic violence, and I'll touch on that a little bit longer. So as you can see, there's a variety of representation in the market. Most of the people do come from Latin America. The yellow, blue, and red flag that you see is mostly Colombia, but there are people represented from all around the world that are also BME and typically migrants. However, they've all coalesced under the name Pueblito Paisa because of the importance this market has to the Latin American community in London. So this market, along with another market in South London, are the largest employers of Latin Americans in the UK, of which they are roughly 250,000 people in the UK. Most of the Latin Americans in the UK are from Colombia or Brazil. And like I mentioned, most of the workers in the market are women. One of the most notable issues that kind of is the crux or the background to this research is that Latin Americans still lie invisible to the UK government, meaning that there's no ethnic category for Latinos or Hispanics or however, which means that there's virtually no health data. So I approach this kind of from a blind spot, and there's two sociologists based in London, Kathy McIlwain and Patria Roman Velasquez, who have kind of spearheaded the research and available information there are for Latinos in London. So unfortunately, in 2005, the market had been targeted for urban renewal, which you see on the right, following suit of North London's regeneration. This led to what Sofia, who is the lead of the resistance movement, calls a doble desplazamiento, which stands for double displacement of the migrant workers from the gentrification of a group that had previously been displaced from their home countries. And Sofia tells me that many of these workers who had fled from their countries actually live with a form of PTSD. Now, a lot of the literature on migrant health and trauma has been used in structural frameworks by anthropologists. However, that can lead to repetitive and harmful tropes of the traumatized or suffering migrant. So I try to push on that a bit because it can often neglect agency, flux, and uncertainty. However, I do ground my ethnographic analysis in Sofia's term of the double displacement, as well as her notion as PTSD. not as diagnostic truths, however, as we say in anthropology, to hold them up for inspection, to understand what's going on. So the main goals of this research, as I will walk you through, are first to discuss how this market has become basically a home for the market users and how that facilitates health and well-being for the Latin American community in the UK. And second, how the effects of doble desplazamiento have led to physical and mental consequences amongst the Latin American migrants. My methods are primarily anthropological. It was an ethnography of this market where I observed, had informal and formal semi-structured interviews, and used a concept called reflexivity. So reflexivity is being conscious of my own positionality and the effect that has on the field. My own positionality being a white passing male, a customer, a student. However, being Latino and a native Spanish speaker myself did actually give me a lot of access to discussing and getting to know a lot of the migrant workers. Tori was actually the one who pointed me towards Linda Alcoff's The Problem of Speaking for Others. So I don't want to tell these people's stories for them, but rather share you the experience I had in doing this research. And all the photographs are mine unless otherwise stated. And I'll talk about my limitations at the end with COVID-19. So this picture just kind of briefly reflects how when you walk into the market, it literally feels like somewhere in Latin America. You don't hear English. You just are bombarded with the smells and odors of the food. People are socializing and talking. And at night, the market turns into a club for the Latin American clientele where they're dancing bachata, salsa, reggaeton. So this market actually, in a lot of ways, supports the health and well-being for this typically informal worker base. It allows a space for Latinos in London to self-actualize, where most of them can own their own businesses because they lease out and open restaurants or shops, or become entrepreneurs, especially for migrant women who otherwise would be working in precarious jobs such as cleaning or other industries. However, there is a difference when a migrant space literally feels like home on a multi-sensorial level, a difference in being able to facilitate health and well-being. So this builds off the conversation of embodiment that actually Tori talked about earlier, where I elaborate on the anthropology of embodiment, discussing how bodies are indeed leaky and they dwell in complex interactions with sensorial intimacies. This means that the odors, the smells, the Latin American environment that surrounds the community actually becomes a part of their health and well-being. So I use the term chemical kinships, which was first termed by anthropologist Elizabeth Roberts, and how these social relationships form around the preparation, serving, and consumption of food in the space. So the food was really important to this identity and the health and well-being. On the left, you see sancocho, which is a traditional Colombian stew, where one of my interlocutors, Omar, talked about how important this was because of its warming abilities for both the stomach and the heart. Then he also walked me to another shop where they were selling cheese, and he says, I come to this market every week for this cheese because it's exactly like the cheese I used to have back in Colombia. It tastes exactly like the cheese back home, and it just makes me feel so welcome, or at least like he has a place in the UK outside of the invisibility to the state that I talked about. So in this way, these chemical kinships, which you see people bringing their children, their families, just going to the market to socialize, it facilitates a safe space of care and love by which people look out for one another's health and well-being. Now, while you may think that care and love might seem like soft terms, often reserved for well-being, Lynn Harbottle has argued that the devaluation of well-being to health is actually a Western and hierarchical construct, and that in the UK, a mind-body dichotomy has prevailed, where well-being is typically seen as less important and not part of health, which I refute. So this care work, such as caring for each other's kids, having a space where they can practice Spanish or eat their food, creates a homely space that minimizes, quote, harmful, threatening otherness, from another anthropologist, where one can govern by their own rules away from outside class and patriarchal hierarchies. So this next picture, it almost looks identical to the last picture. However, what you wouldn't expect is that this picture was taken right after a gas leak had been reported in the market. So unfortunately, the concept of embodiment also applies to potentially harmful things such as chemical gas leaks, detritus, or the crumbliness of the building. The building is actually over 100 years old, had previously been abandoned in the 1970s, and in the 1990s, the Latin American migrants had come in and reconstructed this space as their own, creating what is now today Pueblito Paisa. However, this market remains neglected. Now, that's not my word, but rather ones that my interlocutors share with me, because people have been pushing for, the migrant workers have been pushing for renovations and updates to the market because so much of it remains unused. On the left, you see this whole section that's not safe for use, and it's actually posing a potential occupational hazard. However, the city and the development company that's doing the gentrification has not addressed these renovations as a way to strengthen their case for complete demolition, according to my interlocutors, to the point of one of them calling this place a, quote, shithole. Excuse my language. So like I said, in 2005, this market was marked for complete demolition and regeneration, which would price out the migrant workers for a wider and wealthier clientele. However, like I mentioned, every time they propose a community-led regeneration plan, their pleas are ignored and they're met with discrimination. Sophia, the resistance leader, has shared with me that over the last 15 years, men and women of the market have received forceful eviction threats from the development company, facing racial slurs, and again, excuse my language, like bloody fucking immigrants, this is England, not Colombia, and Sophia, who's a very strong female leader leading this whole resistance, getting called a fucking bitch. Sophia took this case to the United Nations, both in 2016 and 2019, where they ruled the case as a potential social cleansing. However, nothing has been done to stop the regeneration. So as you can see, this is the encroaching kind of like skyscrapers that are approaching Tottenham, where the market is located, which is does not look like this. So I build off the literature and anthropology of subjectivity, trauma, and mental health to argue that the effects of doble desplazamiento are the layering of trauma of a future home loss from gentrification over the existing trauma of a previous home loss, where they had to flee their previous countries. Feminist philosopher Judith Butler writes on the paradox of power and subjection, and how when a subject fights to be recognized by a greater power, in this case, Latin Americans trying to be recognized by the British government, they actually reify that structure's power. In this case, that subjectivity to the power becomes internalized and emerges as what Butler calls a melancholia. For my research, many of the migrant workers actually had developed or sustained depression, anxiety, and even alcoholism due to the precarity and fear of losing their jobs through the gentrification. Butler writes, quote, "Melancholia is the limit to the subject's sense of the French word pouvoir, its sense of what it can accomplish, and in that sense, its own power." So it leaves us kind of wondering, what is left for the resistance movement to keep doing? How are they going to keep fighting? One of my interlocutors, his name is D, who's a lifelong native to Tottenham, told me that the gentrification he's observed in the community has left many people disenfranchised. Businesses are no longer owned by the ones you would expect, which he refers to Black and brown business owners, being lost to rent or pricing out or other factors. Again, in the case of the market, to connect this to the broader theme of the research conference, Latin American women are the most affected through the removal of the space that encourages their entrepreneurship and their ability to own their own business. So again, these effects of race, migration are not isolated, and gender, they're actually completely intersectional and all intertwined. So lastly, a community has really emerged not only in the market, but around trying to fight for the village. In the middle, you see one of the women leaders of this resistance movement, and they're still fighting to this day. So in March, I had to leave London and stop my research because of coronavirus. However, the market was actually completely shut down, even though most grocery stores remained open. And even now, it's September, the market remains closed, and the migrant workers have not been able to work for the past almost 6 months, where again, because of this intersectional approach that I keep mentioning, women end up being the most affected. And again, you start to wonder, like, why is it the women who are also taking on that burden and responsibility to lead the resistance movement, you know? So there's a lot of kind of intersectional issues, and I encourage you to realize that they're not isolated. So this is just kind of an overview of the situation. I appreciate the ability to share, and I'm looking forward to your questions. Thank you.
Awesome. So thank you so much to our second panel. Those were absolutely excellent presentations. So I'm going to dive right into the Q&A here. So if you have any questions, once again, you can just put them in the chat, or if you want to ask one on camera, you can do that as well. So we have a question from Kendra here. Thank you, everyone. How do you all plan on influencing the feminist perspective in your capacities as budding researchers? Do you have any immediate ideas on how to improve the current disparities seen across sociology, philosophy, and medical models currently at play? So I think that's a great question. That's a very big question. If anyone wants to tackle it. What might be interesting too when putting these panels together, I did put Lotte, Rachel, and Scott together because of their focus on community and the power behind that. But also your three's position within medical care. So Lotte is a doctor, Scott is a medical student, and Rachel's a hopefully soon to be medical student. So maybe if you could speak on that a bit about how you could see bringing this feminist perspective into medicine to create some change.
I obviously work as a doctor at the moment, and I obviously mentioned already in my presentation that doctors had emailed the founder of GD Mums to say that actually their engagement with GD Mums as, you know, patients or women with GD themselves had changed the way in which they were interacting with patients. And certainly on a very kind of individual level, I came across a woman with GD when I was doing a shift in the emergency department a couple of weeks ago, and she was saying that she'd just been started on insulin and she was quite miserable about it. And I asked her, like, oh, like, what are you doing diet-wise? It wasn't part of the consultation, you know, I should come for a separate issue. And when she said about diet, I suggested actually like trying some of the dietary changes of GD Mums. And so I think that's very much been my focus about, particularly as a doctor, to think about the ways in which medicalization hasn't necessarily been a one-way process, and so, you know, in ways that are good, that actually, you know, people have been able to exert their own agency and make a change to their medical care. And so I think just an awareness of where people have done that and being alert to the fact that there are actually lots of patient groups out there, lots of, you know, social activist movements which are not even necessarily pushing back against medicalization, but engaging with medicine, engaging with medical practices, suggesting new things, and to be really alert to that, and to be listening and looking out for that, because it's definitely out there if only you try and find it.
I would add on to that. I think that's a really, you know, important point in terms of thinking about how we connect with advocates, and how as doctors we really try to listen to the stories of all of our patients. And I think, you know, in medicine, I'm hoping that when I become a doctor, I can run, you know, I've sort of had this background on the history and sociology of women's illnesses, and I'm hoping to be able to take that knowledge and, you know, conduct clinical studies exploring how, you know, socioeconomic status affects postpartum depression, and how, you know, women of color are more likely to suffer from postpartum depression than any other group, and sort of being able to take into account these various factors. I think having the background in feminist health research will allow me to be, you know, a much more empathetic doctor, and will allow me to, you know, seek changes on the patient level, but also on the policy level, and thinking about how medicine is so interdisciplinary. And yeah, I think it's really empowering to have this background and to hear from so many different researchers, and see how we'll be able to make a difference in each field we go into.
Yeah, just to add on to that. So already in my 2 months of medical school, I feel that having a feminist lens and just contributions from the social science can be so beneficial and important in highlighting the effects of power dynamics and also biases in medicine, right? So biases on behalf of the doctor, and the consequences of institutional power within the healthcare system. So being aware of that, I think, is one step, because I think the question is very hard to accomplish, you know, but I think that's just one step towards realizing, kind of like Rachel had talked about, a historical approach to why so many illnesses, especially within women, were historically contingent or emerged out of maybe discrimination against women or people of color. So one example too is like in Texas, for example, we have one of the worst rates of maternal mortality, and Black women are also 3 times more likely to die from childbirth than a white woman. So I think being aware of these like discrepancies that are completely, have been proven, like scientifically proven, to be completely contributed from discrimination, racism, disproportional effects of like power and social issues, I think kind of that's one way to start the conversation, and being aware of how important that is in medicine, like Rachel said, how interdisciplinary medicine actually is.
Great. So we are running out of time, but I'll give another few minutes if anyone has anything to add to the chat. It can be for either panel at this point. That'd be great. Okay, this is from Laura. Thank you for all the excellent and informative presentations on your feminist-focused research. Question for Scott. Please clarify who, which entity owns the building that the markets are housed in. Do the mostly women merchants pay rent? To which entity? I am leading to an ultimate conclusion that the center of gentrification is capitalist forces, huge money and profits being the same overwhelming giant to fight. My question. Okay, there's a few questions here. How can these groups of women in these markets get more support for their causes, and from whom? So if you want to start off with sort of like who owns it, what's that structure like, and then how we can better support these women.
Yeah, thank you for that question, because sometimes it's just so easy to kind of say, oh, they're fighting against the city or the development company. But so specifically, the market is owned by Transport for London, the same government entity that owns the metro, the tube, and like a lot of other of transport industry in London. So when they pay rent, they actually pay it to Transport for London. However, the prices are very cheap right now because they live in a northern kind of like suburb or like outskirt community of London, not necessarily the center. And it's affordable because it was previously abandoned as well. So this kind of just facilitated a space for migrants who typically come in at a lower social rung to open up businesses. So then the city kind of like runs that entity, but then they hired a development company. I can't remember the name off the top of my head, but basically the development company is in charge of the regeneration, and they've been there for a long time now, but they don't listen to the heeds of the renovations, kind of like I talked about, and are rather kind of pushing for complete demolition and filing eviction threats to get these migrants to leave at their own volition, which looks a little less, on paper, it looks less bad than if they actually are just forcefully moved. So eventually they leave because they can't stand the discrimination and the price gauging anymore. The second question, I think it's a little harder because Sophia, for example, these are all pseudonyms, but Sophia, for example, who led the resistance movement, has been struggling with this question for the past 15 years. She took this up to the United Nations, and still the ability to seek help in this kind of situation is very limited. I think you're right. I think there is this insidious and maybe kind of like not straightforward of capitalist force with gentrification, that it's kind of just driven by market forces, and that it's almost inevitable, right? Because the city is expanding and now encroaching into like outskirt communities. However, if you go to their website, if you Google Pueblito Paisa or the Latin Village in London, they do have kind of resources that they've pulled from. And I think just kind of community organizing, which was like the theme of this one panel, community organizing and kind of grassroots organizations are a really powerful way of mobilizing the community. And I think they've made some gain. However, it is very difficult when the city is paired with this development company as opposed to a development company in its own right. So I think that second question is harder to answer, but I hope that gives a little bit more insight.
Awesome. So I won't keep you much longer. We'll end with this final question, which I'll sort of expand to everyone. Yeah, and again, I know some people didn't have their emails on their slides. So if you want to just message Medical Herstory on email or on social media, I can relay them to any of our great panelists. So this one's for everyone. How are online resources becoming crucial for feminist health research and progress? And why do you think this is the case? So maybe that's something we can also think about when we're talking about communities that were maybe more on the ground, how those have been changed in recent times, becoming more remote or operating online. So I guess I can start off with plugging Medical Herstory, of course. So I feel like when you create online communities, you're really expanding what's possible. You're really being able to connect people with shared experiences all across the globe, honestly, and really just work to destigmatize these issues. I'm really curious to see how feminist research is going to take shape online, and especially with these communities as we do move forward.
the internet was my everything in my research, because unlike everybody else, I didn't actually speak to anybody while doing my research. I relied on academic papers and academic discussions and forums and things that were online, so reading journals and things like that. And without the internet, I would just be left with my own thoughts. So it was crucial to hear what different people from around the world have been thinking about in these areas. So yeah.
Obviously, I was looking at an online community, so of course that online element was central to women's experiences of GD in this case. But when I was researching, I was also looking as a bit of background at other communities, and there were lots of examples I found of feminist health research that focused on online communities. So one in particular, which I use quite heavily in my own work, was a paper by a sociologist called Emma Whelan about online communities for endometriosis. It was specifically a mailing list called Wits Endo, which I thought was quite a good name. And that was just really interesting research if anyone wanted to read it. But yeah, I think absolutely that the power to connect people from all sorts of different places, and just the combined with the accessibility of so much more information that people now, have at their disposal, I think it makes a huge difference in the kind of activism efforts that women make with each other.
Yeah, so I also used like online resources like Facebook in particular to recruit my participants for my undergrad dissertation and my postgrad dissertation. And I really struggled, especially for my undergrad, to recruit people kind of in real life. I tried really hard. I handed out 500 leaflets. I went to classes. I went to loads and loads of things, went to doctor surgeries, and just like, I think I got 6 people after like 500 leaflets. And then I had someone in the Lecture League post something online for me, and I got 100 emails in 24 hours. So from like a recruitment point of view, not recruitment, but looking for participants, recruitment, that was really helpful. But also, especially thinking about like the experiences of women, with breastfeeding, that a lot of women or families in the early postnatal period, you can be quite stuck indoors. And especially if you're breastfeeding for like 15 hours a day, sometimes it's quite hard to get out. It's quite hard to access the outside world. So a lot of women I was speaking to were really responsive, because they would just be sat on their phone while they were breastfeeding. Like the whole time they were breastfeeding, they'd be like on Facebook and chatting to people about it. So it was actually kind of like this other world that women were connecting, and a lot of women on antenatal groups were like sharing their experiences at 3 a.m. while their husbands were asleep, and they were kind of looking at them resentfully, and they were talking to each other about it. So it was really helpful on those 2 levels. So yeah.
So thank you so much to everybody for coming, to all of our amazing panelists, especially those who adapted their research just for this talk. That was awesome to see what you were able to do with it. So I hope today inspired you all to think about how you can bring a feminist lens into your own research, or your lived experience, or just generally your understandings of health and illness. So I encourage you all to check out Medical Herstory to hear more about future events like these, to keep the conversation going, or to get involved with us as we continue to advocate for compassionate and comprehensive healthcare for all. So I'll end the call now, but thank you again, everybody, so much.